You, Satya. Good evening, everybody. We will move on to the third part of the session of tea. And I'm not wasting much time as all of us know Vineetha very well. So it's over to you, Vineetha.
Yeah, good evening, sir. Good evening, everyone. There is a little bit of internet connection problems on my side, I feel. We'll see how it is. I'll share the screen anyways. My computer or internet, something is behaving very slow, which so just give me few minutes. Yes. Can you see my screen, sir?
Yes, ma'am. Yes, yes.
Okay. Okay, so we'll start with the third and the last session. So it's a very small presentation. And after that, if you have any doubts, you can ask me. And whatever I know, I'll answer. And I think Sunil sir, Amarda, everybody are here. So we can have a meaningful discussion. So today's third part, so we have already dealt with low back pain, then fibromyalgia, myofascial pain, neuropathic pain, CRPS. All these are very common conditions that pain and palliative physicians will encounter. And another important problem that we have, I'll come to that. Let's see whether the slide is changing or not. This is another problem. Yeah. So we'll come to the case scenario and you'll understand that. So this is a 68-year-old lady with right-sided knee pain for 1 year. And pain was of spontaneous onset and it gradually worsened. And the pain is felt diffusely in and around the knee. And she also experiences a radiating pain from the buttocks to the middle of the calf, right calf. The pain is of a stretching kind and worst on walking, climbing stairs, etc. And she also occasionally feels weird sensations within the knee, as if some organisms are moving inside, and no early morning stiffness. On X-ray, there was grade 2 osteoarthritis changes in the knee, and due to severe pain, so she consulted a local hospital. This is not in our institution. She came to our institution later, the institution where I did my fellowship. I saw this patient there. This is a real story of that patient, but she came there later. This is a story before that. I should have used past tense. Sorry, I used present tense. So basically, she had grade 2 OA changes and severe pain, physiotherapy, analgesics. That was not helping her, and she underwent a knee replacement in a private hospital there. But her symptoms persisted and she underwent another surgery to correct the implant. She was told that there is some problem how the implant is kept. So she underwent another surgery. But again, there is no relief to pain. And the surgeon, as usual, asked for a psychiatric consultation because everything else is normal. I have done surgery twice. Your knee is perfect. You are still having the pain, means something is not normal in your head. Then, however, she refused to see psychiatrist, and since she already saw many orthopedicians and many doctors outside, and she got frustrated, fed up, and she finally consulted a pain physician in our hospital, in the institution where I was studying at that point of time. So I'm not, telling the entire examination findings because we need something for discussion. So I will tell her about the right knee. There was no effusion, no crepitus, because already the surgery has been done, but this was the finding before the surgery also. I saw in the discharge summary, there was no effusion, no crepitus, but there was minimal joint line tenderness. When you palpate that exact joint line area, there was minimal tenderness. And her range of motion, ROM means range of motion of the knee, flexion, extension, pain was there. But it was she had full ROM. The ROM was not restricted, but it was painful. So this is a story. So I just wanted to know what are the differential diagnoses in this case, because she had a knee pain, she underwent surgery, the pain is persisting. The same pain which was there is persisting now also. And before the surgery and after the surgery, these are the findings on the right knee. And X-ray, there was grade 2 OA. Now, what are the differential diagnoses? Again, I had a tiring day, and I had a class in Palim in the morning also. So I will use that as an excuse not to talk much. You will talk, and we will discuss. Okay, now tell me, what are the differential diagnoses?
Ma'am, could the pain because of some hip joint, because there is a
hip joint. Okay, that means you are telling that it is not from the knee joint. It could be possible. Okay, then another differential diagnosis.
It could be some disc-related problem because something like that. That's why it's radiating from the buttocks, etc.
Due to some reason, I am not understanding who is telling
So
the answer.
Stravani, ma'am.
Yeah, first one was Parul, Dr. Parul.
Yes, ma'am.
Who told
Yes.
hip? Yeah. Okay. So that is second. Any other differential diagnosis? Anything else?
Any loose body, she feels like some organisms were moving in around the knee. Things related
Yes,
to some loose body formation.
Okay, so you're telling it was the pain generator was within the knee itself. So we got knee, hip, lumbar disc. So anything else? Okay, I think that is enough. Anyway, you all got, I think, that point that when somebody complains of knee pain, it necessarily may not be from the knee, because if it was a loose body or if it was something from the knee, she could have actually got some relief after the knee replacement. Okay, and of course we can say the surgery might have gone wrong. In lumbar spine, we say failed back surgery syndrome. The patient had a spine surgery but still having complaints. Similarly, this can be a failed knee surgery also. That is also a possibility. But actually, the rest of the findings was interesting for this patient. So this patient, we somehow were convinced that it is not her knee, because what are the points? One, the radiating pain from the buttocks to the middle calf. Okay, knee pain patients can also have radiation, but knee will be the epitome. Knee will be the center. From there, they will feel that it is going up, it is going down. But here it was from the buttocks to the middle calf. Okay, and then stretching kind of pain. Then worst on walking, because knee pain patients, of course, they will have pain on walking, but most of them will say that they will have extreme difficulty while standing up from a sitting position. That flexed knee going to that extending, position, that was not there. Her pain was mainly on walking. And this weird sensations. This is basically a type of neuropathic pain. Okay. All the patients will not say it is tingling, numbness. Some people say like this. Okay, this is a neuropathic feature. So all this, along with we got a positive SLR, and that, like Dr. Sravani correctly told, this was actually a lumbar disc problem. We gave a diagnostic transforaminal epidural steroid for this patient, and she got complete relief of pain, which she was suffering for almost 1.5 years, and underwent 2 surgeries in the knee also. So again, in the examination, these points, the minimal joint line tenderness, that is what I am coming to in this class. How will you identify that knee as a pain generator or shoulder as a pain generator? So usually if knee is the pain generator, especially in intra-articular problem, let's say osteoarthritis or rheumatoid arthritis, there will be marked joint line tenderness will be there. Okay, significant joint line, usually, I cannot say in 100% cases, but usually there will be joint line tenderness. And ROM, it will be painfully restricted also. Okay. Now, this patient, which radiculopathy causes knee pain? It is L4 radiculopathy. Okay. The L4 radiculopathy presents like this, from buttocks to calf. It will not go till our toes. L5 and S1, which are more common, it goes like that, till the ankle or till the toes. But L4 usually stops somewhere in middle of the calf, and patients usually complain of knee pain, something neuropathic features. Instead of neuropathic features in the toes, they will say neuropathic features within the knee. Something is crawling inside my knee. So this is basically, this was a disc disease, and the intention of this class is also to identify whether pain is from the joint, around the joint, or completely outside the joint. So that you have to identify so that you can help these patients. So coming to the joint pain, so I'll be discussing only 2 topics in this one. One is joint pain, second one is chronic calcific pancreatitis. And in joint also, I'll be discussing just a little bit about a general approach, and then knee and shoulder, because all the joints I obviously cannot cover in one class, and that also very superficially. In the module that I have given, I have written little more, but in this presentation, it is very superficially, just to identify the pain generator and to exclude the red flags and all. That is our intention. Okay. Now, this study, again, I'm quoting this study. It found that 20% at least 20% Indian adults suffer from chronic pain. So do you know which was the most common chronic pain condition, the most prevalent chronic pain condition in India? It was knee pain. The second was low back. Okay. Now, so the general approach to joint pain. So first, we have to identify the pain generator. This is not knee, generally for joint pain. We have to identify the pain generator. And why it pains? What is the etiology? Why is it inflammatory, degenerative? So these points we will be discussing. So this is just a knee I have provided as an example. So we know this is the knee joint proper. We have femur, patella, tibia, and fibula. Okay. So there is a joint between the femur and the patella, as well as the femorotibial joint. Then we have so many other structures. This is the quadriceps muscle that we are seeing, quadriceps tendon, patellar ligament. We have medial collateral, lateral collateral ligament. We have the menisci. We have the iliotibial band coming and attaching to the tibia on the lateral side. There's so many structures in knee. Then we have so many bursa. You might have studied during the MBBS times, no? Prepatellar, housemaid's knee, clergyman's knee. So we have this suprapatellar bursa, prepatellar bursa, so many bursa. So the joint, this is an example. A joint pain can be from within the joint, or it can be from the structures outside the joint, like ligaments, tendon, bursa. So the first, our target is to find whether it is the pain generator, whether it is articular or periarticular. So if it is from the joint, there will be joint space, which I told now. The tenderness will be very close to the joint space, and joint line will be markedly tender usually. And swelling is common. When the problem is within the joint, swelling is more common. Then this is very important, that both active and passive movements are painful. Okay, that is when patient tries to flex her knee, or you are trying to flex the patient's knee, both movements are equally painful. And these findings like crepitus, instability, deformity, these are also common when it is articular. Now, when it is periarticular, that is from tendon. suppose it is from a tendon, which helps to lift the arm. Okay, so when the patient lifts the arm, this tendon has to work. This muscle and tendon has to work. Then only the patient will be able to raise the arm. So with the patient, when she is trying to raise the arm, this tendon is damaged, so the patient will have pain. But when you are raising the patient's arm, this tendon is not working. There is no need for the tendon to work. You are raising the patient's arm. So the passive movements will be less painful. When you are doing, it will be less painful. So that is one important feature that differentiates with periarticular. Active movements are more painful and passive is less painful. Then the area of tenderness will be away from the joint line. You can see in this thing. Just imagine the patient is having a presensory, the bursitis. It will be, the pain will be here. The joint line is here. Okay. If it is intrapatellar bursitis, it will be here. So it will be away from the location of pain, as well as the maximum area of tenderness will be away from the joint line. Then the swelling can occur with superficial bursitis. There will be a small swelling, but it is less common. And this I have already told. And crepitus, instability, deformity, all this will be less common. That is how the first step is to identify whether it is articular or periarticular. Now the second step is white pains. So what are the common etiologies that you know? As I told, mainly it is inflammatory and degenerative. So now you can tell me, how will you differentiate? What are the ways in which we will differentiate between a inflammatory joint pain? And it's very easy, because we might have studied this during our MBBS times, and I have been telling that in the last class also, how to differentiate between inflammatory and degenerative.
Inflammatory is acute onset.
Okay, inflammatory can be, joint pain can be acute or chronic, but it can present as acute exacerbations. That is true. Okay.
Warmth is more in inflammatory.
Pardon?
Warmth near the joint is more warmth.
Yes, you mean local rise of temperature.
Local
Yeah,
rise of temperature.
correct.
Swelling will
Local
be
rise
there
of
in inflammation. Joint
yes,
swelling.
more swelling will be there. Local rise of temperature, then
Redness and
redness. Obviously, there can be some redness. Okay.
Inflammatory markers will be there.
Okay, inflammatory markers may be negative. Sorry, positive. Yeah. Before that, clinical examination, when you are just looking clinically, what is the most important point? We have been talking that in the previous two classes also. For an inflammatory pain, the patient will have?
It will be worse in the morning. Inflammatory pain will be worse in the morning, and osteoarthritic pain is worse in the evening.
Yes. So it is stiffness, early morning stiffness. The inflammatory pain, not just early morning. Whenever the patient takes rest for some time, the pain will be worse. Okay, but when the patient is walking, the pain will gradually reduce. That is for inflammatory. Whereas it is degenerative, osteoarthritis, patient will wake up, in the morning with a little bit of stiffness, maybe for 5 minutes, 10 minutes. But after that, she will the worst pain she will have when she's walking, when she's doing work with activities. So these are the points in favor of an inflammatory joint pain. Okay. So we have told almost everything: early morning stiffness, warm temperature, then erythema, then deformity, instability. These things are more common with, damaged joint, like genovarum, that kind of deformities. And one thing that effusion will be more here. All this we told, and maybe, crepitus. Crepitus will be more in a deranged, degenerative joint. The inflamed joint will have a soft, duffy feeling, as we fear, the wheat flour, we roll it for chapati making. That kind of a dovey feeling we have when we palpate the inflammatory joint. Whereas that grating sensation, crepitus, that we get in the osteoarthritis joint. So that is how we differentiate an inflamed and a damaged joint. Now, temporal and spatial pattern. So now you know whether it is from the joint or outside the joint, whether it is inflammatory or degenerative. Third point is temporal and spatial pattern means whether it is temporal means timing, what is the duration, acute or chronic. number of joints involved, whether it is monoarthritis, oligoarthritis, and polyarthritis. Then the type of joints involved, like it is axial joints like sacroiliac joint, hip joint, or the peripheral joint, like the small joints of the hand. So what kind of joints? Large joints, small joints. So this is important. And then the pattern of joint. This, I'm not reading all these things, the pattern, you can read that later. But all these are important in arriving at a differential diagnosis. Then the systemic symptoms or associations, because along this is something we missed in inflammatory arthritis. If the patient is having an inflammatory arthritis, patient will have extra articular manifestation like skin changes, bowel bladder issues, uveitis. Okay, so all this systemic, the prominent extra articular manifestations means we are dealing with an inflammatory condition. And also this is associated features are important because that can point towards other causes. A shoulder pain may be a referred pain from the heart, angina, or as I told in our case scenario, a pain in the knee may be referred pain from L4, or a radicular pain from L4 radiculopathy. So the extra articular other features that you have to look for. Then the causes of chronic joint pain. This also I'm not reading the all the causes. As you all know, if it is a single joint is affected, we have to think of osteoarthritis, trauma, and inflammatory. Usually inflammatory arthralgias are polyarthralgias. It involves multiple joints. But when it is crystal arthropathies and septic arthritis can present in a single joint. Then polyarticular, that is multiple joints are involved. It can be inflammatory arthropathy, sometimes degenerative osteoarthritis can also affect multiple joints at the same time, shoulder and knee, hip and knee. So it can cause, and this is important. Some drugs can cause polyarthralgia, and because you will be practicing, pain and palliative in oncology population, taxanes, drugs like docetaxel, paclitaxel, this can cause polyarthralgia. Some malignancies can present or can have polyarthralgia, especially hematological malignancies more than breast and lung. Several infections, then metabolic causes, all these can produce polyarthralgia or multiple joint pain. And then there can be periarticular causes, which I already described, from tendons, bursa, ligaments, etc. So these are the common causes of chronic joint pain. Now, so coming to the history taking, so again we go with the Socrates and red flags. So can you tell me what are the red flags in a joint pain history taking? When you are asking the history, what are the joint possible red flags? Red flags are same everywhere.
Range of movements.
Pardon?
Range of movements severely restricted or
range of movement severely restricted can happen in severe OA also, severe osteoarthritis, severe rheumatoid arthritis. Anything else?
Sudden onset.
Yeah, sudden onset, especially when there is a history of trauma, or when there is, that is one thing, history of trauma and sudden onset.
Severity is high. Very high.
That is not responding to the conventional analgesics. We already know that is a red flag. So one thing is, somebody told sudden onset. Sudden onset, why do you say sudden onset as a red flag? One is trauma, another one is very important. Yeah.
Septic
Arthritis, infection. The delay in diagnosis can lead to the complete joint destruction. So infection and trauma. So that is why sudden onset of pain is important. Then severity of pain, not responding to any analgesics. Then other red flags.
Fever.
Yeah, fever.
Pain during night.
Night pain is usually considered as a red flag, but one exception is shoulder pain. Because all patients with periarthritis, frozen shoulder, they will have night pain. They will not be able to sleep on that shoulder. So, but still night pain is usually considered as a red flag. So then features, I told, hematological malignancies can present as multiple joint pain. So what will be the other features there? Or any malignancy, loss of appetite, loss of weight, cachexia. So all these can be considered as red flags. And this extra-articular manifestations, why I have written is we have to identify a rheumatological condition earlier. Okay, because again, if there is a delay in diagnosing a immunological condition, again, joint destruction, deformity can happen. So all these are red flags, and these suggest tumor, trauma, infections, systemic inflammatory disease, referred pain. So all these are the red flags. Then coming to the examination. So there is a general examination is very important in joint pain, especially if the patient is coming with a multiple joint pain. Then general examination is very important. You have to look for all the extra-articular manifestations and the typical findings. Gait is important because the patient will have antalgic gait in knee or osteoarthritis. System examination also is very important because, as I told, many systemic diseases can present as joint pain. So for example, hepatomegaly and arthralgia means it can be chronic hepatitis, SLE. So system examination, all the system examinations are important. Then local examination, we have already discussed this. We have to look for any swelling, erythema, deformity, scars, palpate for local rise of temperature. Where exactly is the tenderness? Close to the joint, away from the joint. So the tenderness, crepitus, any audible clicks or snapping sensation. Then range of movement, active as well as passive. Because if both active and passive are equally involved, it is likely to be an articular problem. If passive is less affected, it can be a periarticular problem. Then there are special tests for each joint, which is beyond the scope of this class. Okay. So this is just a inflammatory joint. Now, blood investigations. So this is a chronic joint pain. We are not worried about the acute cases, sudden onset cases. Now, from this slide onwards, we are dealing only with chronic cases because it is very unlikely an acute joint pain will come to us. So we'll deal with the chronic joint pain. So ESR, CRP, all these rheumatological markers, if you feel there is an inflammatory component, you should do that. Now in chronic joint pain, the patient is having pain for so many months. What is the situation in which count and blood culture becomes important? Because if already patient is having pain for so many months or so many years, what is the situation in which a count becomes relevant or a blood culture? Culture means anyway you are looking for an organism. So when that becomes relevant in chronic joint pain, any idea? No idea. So
Effective endocarditis.
no, I'm telling something else actually. Why? Because the patient may be having a rheumatoid arthritis. Typically is a rheumatoid arthritis patient. She may be having joint pain for many years. Okay. But now she has come with the exacerbation of pain in one joint. Okay. In one particular joint. In that case, you have to think of septic arthritis. Otherwise, septic arthritis is usually an acute presentation. But sometimes, whenever there is acute flare-up of a single joint pain, otherwise a patient is who is having a polyarticular pain, rheumatoid arthritis patient. But now she has come with a flare-up in one pain. So this is knee is just an example. Any one joint, there is flare-up with marked effusion. And believe me, septic arthritis will not have always a dramatic presentation like warmth, redness, fever. Sometimes fever, especially immunocompromised patients. These patients are on immunosuppressant drugs, rheumatoid arthritis patients. So there won't be any, there may not be always fever or other systemic symptoms. So that is why whenever there is a single joint flare up, you may go for a synovial fluid analysis just to exclude, and blood culture and CBC just to exclude the septic arthritis. So when you have rheumatology patients, this point is very important. Okay. Because you may think, oh, she's already having joint pains for so many years. Now she has come with an exacerbation. That's it. It's not like that. This possibility you have to consider. And uric acid, if there is suspicion of gout, patients on diuretics, etc., then you have to do a uric acid assay. Then synovial fluid, as I told, there's not much role in chronic joint pain, but when there is suspicion of septic arthritis, you can go for a synovial fluid analysis. This is how the normal synovial fluid looks like. In degenerative joint, slight turbidity may be there, but this septic arthritis, it will be so purulent like this. This is usually a bloody tap, okay, or pigmented bilionodular synovitis and all. You can get this color or a bloody tap. Then we come to the investigations. So the imaging in X-ray will help. Definitely, if there's a history of trauma, you should definitely order an X-ray, and also to assess the disease progression, extent of damage. You can see in the X-ray. I'll come to that in the next slide. And nowadays, what is becoming more popular is ultrasound. We all have ultrasound in the OPD. We can get to know a lot of things. How is the tendon looking? Is there any bursitis? Is there any effusion? All these we can see in the ultrasound. And one important advantage with ultrasound is, two important advantages. You can do a dynamic examination. You can ask the patient to move the limb and see how the tendon is working in the ultrasound. You can see how the tendon is moving. And also, you can always compare with the opposite side, which is not very cost effective in MRI. But in ultrasound, you can easily compare with the opposite side also. So these are the, if you have a good sonologist who has experience in musculoskeletal ultrasound, instead of sending the patient for an MRI, you can send for a musculoskeletal ultrasound. It will give a lot of information, because this will be very cost effective for the patient. That's why I'm telling that. Another thing is advanced imaging modalities only when there are red flags present. Then you can go for MRI or bone scan when you're suspecting infections, malignancy, avascular necrosis, meniscal tears, etc. Okay. Now, so this much was the general approach towards joint pain. And now we'll discuss a little bit about knee and shoulder, the differential diagnosis, management, and interventions. So now you will answer this question. Pain is centered around the joint line or joint space, and usually associated with swelling, crepitus. Pain worsens with activity, improves with rest. Early morning stiffness, maybe of 15 to 30 minutes. Active and passive movements are equally painful. These 5 things we have to see. Now, which is this condition?
Osteoarthritis.
Yes, very good. Yes, I think all of you are clear with this. This is an articular. First of all, this is articular. Active and passive are equally painful. So this is from the joint, most likely. Articular cause, and mostly it is degenerative osteoarthritis. So this is what I was telling. Joint line tenderness. Palpate for the joint and see whether the patient is having joint line tenderness or away from the joint. This is suprapatellar effusion. See, whenever in degenerative osteoarthritis, there won't be marked effusion usually, as in rheumatoid arthritis. So you can see there is a fullness compared to the normal side. There is a fullness in the affected side, and you have to palpate above the patella, the suprapatellar recess. This is where the fluid collects first. So you have to palpate there for the effusion. Not here, not here, not here. It is above the patella. Okay. So next, pain is around the joint space only. Swelling, very common. Pain worsens with rest, improves with activity. Active and passive movements are equally painful. Marked early morning stiffness, 30 minutes to 1 hour. Constitutional symptoms may be present, like fever, loss of appetite. So which condition is this?
Inflammation.
Yes, very good. So this is again articular cause and most likely inflammatory. Sorry. Okay, this is the kind of effusion we get in inflammatory arthritis, gross effusion, not just the suprapatellar area. The entire knee joint will be swollen. Now, the third condition is pain is away from the joint line, crepitus, swelling, deformity, less common. Pain worsens with activity, improves with rest. Active movements are markedly more painful and limited than passive movements. So, which is this condition? They're like articular, periarticular. What do you think this is?
Periarticular.
Periarticular.
Yes.
Periarticular.
So this happens in periarticular. In the case of knee, bursitis, tendinitis, ligament tears, all this will present like this. I'm not talking about acute tears, chronic tears. Okay. So these are the common areas of bursitis, suprapatellar bursa, prepatellar bursa, infrapatellar, pessancin, and there is one posteriorly also, the semimembranosus gastrocnemius bursa. Okay, popliteal, the Baker's cyst. So these are the areas of bursitis. Now, imaging in knee pain, you should know how to grade, even as you know, as the pain and palliative physicians, this much you should know how to grade the osteoarthritis. Why you should know is you can grade the patient correctly, because in the early osteoarthritis like grade 1, grade 2, you can see there is just starting of joint space narrowing. From grade 3 and grade 4, so many osteophytes will be there, marked narrowing of the joint space. You can see marked narrowing will be there, subchondral sclerosis will be there. So the importance is when you refer the patient for a intervention. If the patient is okay for a surgery, then no problem. They will do surgery in grade 1, grade 2, grade 3, and grade 4. But suppose if you are referring the patient, or if you are planning, you yourself are planning for an intervention, then you should know that in grade 1 and grade 2, the platelet-rich plasma, PRP, will help. Whereas advanced degenerative changes, grade 3, grade 4, PRP will not work. You have to go for a nerve block. You have to block the nerves that's supplying the knee joint and go for an RF ablation for a longer coverage of pain relief. So that for that reason, and for diagnosis, if if a patient brings you an X-ray of the knee, you should be knowing whether this is osteoarthritis, and if at all it is osteoarthritis, what is the grade, and then you can grade the patient correctly. Then another, I was telling about the importance of ultrasound. So this is a story of a patient, similar to the case scenario I told. This patient also came in the institution where I was studying. He exactly told this, fix this, even though this is something I got from the internet. This patient came with this kind of a pain from the gluteal region, radiating along the lateral aspect of thigh till the knee. And this entire area was actually tender and painful. So he was posted elsewhere for a lumbar, spine surgery, because he was in his 40s and he was an athlete, or he was, a person who was used to jog a lot. So he had some disc bulge also, and this patient was posted for some spine surgery, and he wanted to get a second opinion, so visited our OPD. You know what this was? We had a doubt whether it was coming from the spine, because radicular pain, it will be in this pattern, along the lateral aspect, but unlikely to have so many tender points along this area. This region is very much tender where he is pointing. This region is very much tender, and this region, knee, is also very much exquisite tenderness. That will not happen in radiculopathy. Usually there will be pain, but tenderness is not that common. So you know what it was? We did an ultrasound, and any idea? Runners, cyclists develop this kind of pain. Anybody who might have,
With the iliotibial tract.
Yeah. Who said that?
Kevin.
Kevin, okay. So I ideally give you a gift, but since it's an online class, I can't give you. So happy for you. This is iliotibial band syndrome. This happens in, athletes, cyclists, runners. They will come to you with this kind of pain. They might have gone to several people, several physicians outside. They may not diagnose it correctly. So the clue here is the iliotibial band. It starts from here, the greater trochanteric region. No, it starts from here. It starts above. It passes by the greater trochanter, and then it comes and attaches to the tibia. But even though it attaches to the tibia, lateral femoral condyle is the area where the patient will have maximum pain. Okay, so that is how we just examined. So this is attachment of iliotibial band. So it starts from here and it comes and attaches to the tibia, but maximum tenderness at the site of lateral femoral condyle. So we just did an ultrasound, not this I got from the net, but this was a picture in that patient also. We just did an ultrasound here and here, and we found that beneath the iliotibial band, there was effusion, and within the OPD itself, just 2 ml of lignocaine plus 20 milligram of triamcinolone, the patient who was posted for spine surgery went home. Okay, but thing is that after that he has to do ITB stretching exercise, otherwise he will come back. This is not a permanent relief. He will come back after 3 months or 6 months with the same pain, but we started him on a physiotherapy program for ITB stretching exercises. Okay. So this is the importance of ultrasound. Okay. Don't just go by the MRI or this thing. We should actually use all the investigations and all the clinical features to arrive at the correct diagnosis. So just an example. And now coming to the management, just like in any other chronic pain management, there are lifestyle modifications. I'll come to that. What are the recommendations? Physiotherapy, exercise is very important. Psychotherapy, all this should start from day one. Don't, keep this for the end. All this should ideally start from day one if it is a chronic pain. Then pharmacological management, interventional pain management, and surgical management. So this is just one single slide for what are the recommendations for knee osteoarthritis from the American College of Rheumatology, the recent guidelines 2019. So the dark green means they strongly recommend that. Light green means conditionally recommended. So exercises, self-efficacy, self-management, that is lifestyle changes like walking and weight loss, all these they are strongly recommend. And I told this in the last 2 classes. Tai Chi, ACR strongly recommends for osteoarthritis. Using a cane, a tibiofemoral knee brace, all these they strongly recommend. These things are CBT, acupuncture, you can read this later. And coming to the pharmacological management, NSAIDs, even though you can use it only for a short term, oral NSAIDs, topical NSAIDs, and intra-articular steroids have the strongest recommendation. All these are only for short-term relief, but still they have the strongest recommendation from ACR. Acetaminophen, tramadol, duloxetine have conditional recommendation, but again they are good recommendation, because you have to go back and see this guidelines, read this completely, because there are many other things which are marked in red. That is, they don't recommend at all. For example, they say they don't recommend PRP. Okay, so these are actually, this dark green and light green are interventions with good recommendations, either strongly recommended or conditionally recommended, and not duloxetine. Note this point, duloxetine, your patients who come to your OPD with knee osteoarthritis, you can start on duloxetine. It has got good evidence in knee pain, along with other analgesics and these basic measures. Okay. So that's it about the management. Go back and read this. Okay. And ACR guidelines. Interventions for knee pain. Yeah.
Dr. Vineetha, that one was for osteoarthritis or for any?
Osteoarthritis. Osteoarthritis.
Yeah,
they have hand, hip, and knee in one particular slide, but you just go what is below the knee, then you'll get that. Okay.
Okay. Thank you.
And go back and read the entire guidelines. It is very useful. And I always feel, a sense of security when you are following some guidelines which have utilized so many studies, well-controlled RCTs, and making some recommendation. It is better to go by that.
Okay.
But if I go by that, I cannot use PRP. That is a problem, because ACR does not recommend PRP for knee osteoarthritis. Why they don't recommend? Because they say there are no controlled studies, because there is a lot of variation how every person makes PRP, how much volume they use, how they made it with single centrifugation. That's so much of heterogeneity is there. So they cannot arrive at a good evidence. But anyways, intervention steroids are useful for acute flare-up of OA or for inflammatory pathology like RA. You can do maximum 3 times a year. This intra-articular steroid, and it can damage the joint if you do it more frequently, once in 3 months or even more gap you can give. Okay. Then intra-articular platelet-rich plasma, I already told for grade 1, grade 2. Then genicular nerve diagnostic block and RFA. So this is the knee nerve supplying the knee joint. So we block it here either with the use of ultrasound or X-ray. Then for periarticular, depending on the pathology, just like I said, for ITB, iliotibial, band syndrome, we can give steroids. And tendinopathies, ligament degeneration, we can go for PRP. Platelet-rich plasma has good evidence for degenerated tendon, ligaments, and all, which does not need surgical correction. For example, a medial collateral ligament tear, a long back tear, it is still painful. You can go for a PRP injection in the medial collateral ligament. So like that. So this is about knee. Now a little bit about shoulder. Anything you have to you have any doubts in the knee?
Madam, I've seen that, sometimes with vitamin D deficiencies, a lot of people come with knee pain and effusion.
Yes.
And just taking care of the vitamin D deficiency disappears.
Yes, actually, I have written that in my module also, even though I didn't include that in my slides. Vitamin D and calcium supplementation, most of the literature says, especially for postmenopausal women. We see very commonly in postmenopausal women because of this calcium, calcium deficiency can produce knee pain. So calcium and vitamin D supplementation has a role, especially in postmenopausal females. Okay. Anything else in knee? Okay. Then we'll go to a little bit about shoulder also, because it's very common. Frozen shoulder and all this rotator cuff problems is very common. And just again, we'll be dealing only with a little bit of differential diagnosis. What are the common imaging findings and how do you manage it? So when we say shoulder joint, there are actually many joints in that. The most important being this one, the glenohumeral joint, and this one is the AC joint, acromioclavicular joint. So what are the pathologies that you know that can arise from these joints, from glenohumeral or AC joint? Any joint, what are the common pathology?
Degenerative.
Yeah, osteoarthritis or rheumatoid arthritis. Okay, trauma, all this can happen within the joint. And now the joint has got a capsule, right? So when this capsule becomes inflamed, in the acute stage is inflamed, and later on thickening, fibrosis, and shortening of the capsule, as well as some ligaments and tendons here, that then it becomes a periarthritis or the frozen shoulder. Then what are these muscles known as? Supraspinatus, subscapularis, teres minus, 6 muscles we studied in our MBBS days.
Rotator cuff.
Rotator cuff. So these rotator cuff muscles cover the shoulder joint, just like a, what you call another capsule, or just like a covering. They cover the entire shoulder joint. Okay. So these muscles, especially the tendons, these can have degenerative changes. These can have tears. These can have inflammation. We call this together as rotator cuff pathology. Okay. Now, what is this? A very important bursa in the shoulder joint. This is subacromial bursa. This is clavicle. This is acromion. The AC joint here, and below the acromion, see one muscle is coming here beneath the acromion and coming and attached to the greater tubercle of humerus. Do you know which muscle is this? This muscle, supraspinatus. Okay. The supraspinatus is coming below and coming and attaching. So what happens is, in some patients, there will be less gap between this humerus and the acromion. So the supraspinatus will be constantly impinging on the acromion. So that causes subacromial impingement. The bursa will get inflamed. Okay, there will be bursitis, and that is known as subacromial impingement. Another pathology is, this is you all know the biceps muscle, and it has got 2 bellies. You all know that, right? So this long head of biceps, this is often referred to as the 5th rotator cuff muscle. Okay, and this tendon comes between the 2 tubercles of humerus. This is lesser tubercle, this is the greater tubercle, and this tendon travels here. So this tendon can get inflamed, and that is known as bicipital tendinitis. So now you all know what are the common pathologies. Either the glenohumeral joint or AC joint arthritis, the rheumatoid arthritis, osteoarthritis, rotator cuff diseases, the tear, tendinopathy, tendinitis, whatever it is, subacromial impingement and bursitis, frozen shoulder, and bicipital tendinitis. Believe me, 90% of patients, they will have one of these problems, not more. But it is often difficult to diagnose, but they will have either one of these 5 problems. Okay. So you can read this later, what are the causes. And also these 5 problems which I have already explained, I have written there. The most common differential diagnosis. You should know that osteoarthritis is common in older age people. And frozen shoulder is very common in diabetes, hypothyroidism, And whenever there's a history of immobilization following some fracture or CVA, there is something known as, a shoulder hand syndrome that you see in post-stroke patients, very difficult to treat actually. So whenever you immobilize your arm for some time, and hypothyroidism, diabetes are the three most common predisposing factors for developing this frozen shoulder. Okay, and rotator cuff disease, it can happen as consequence of a major trauma. Suppose an elderly patient, he was trying to rise from a chair. He fell on an outstretched hand. He can have this rotator cuff tears. Okay. And it can also happen following micro trauma or repetitive work. Teachers, basketball, volleyball players who constantly, uses abduction, overhead lifting or abduction, they will have this constant micro trauma to the muscles, and they may develop this rotator cuff disease. Okay. So on examination, you have to look for the range of motion. This is the single most important examination finding in shoulder. How much, these are the various movements: adduction, abduction, flexion, extension. So in frozen shoulder, universal restriction will be there, active, passive, and all the movements will be restricted. But the first one to go is external rotation. Okay, you don't have to know that much detail, I just told. Okay. Then glenohumeral arthritis also, there will be diffuse pain and stiffness. Abduction, more than external rotation, abduction is affected. But what is important is there is a grating sensation and crepitus in case of osteoarthritis. Whereas for frozen shoulder, that will not be there. So that is important. Then I told about subacromial impingement and rotator cuff disease. So if you just want to remember two differential diagnoses, one is frozen shoulder and one is rotator cuff. Okay, you forget everything else. Why I told you to forget everything else is AC joint is very easy. They will pinpoint here. This is my problem. Okay. Or when you press the next slide, I'm showing that when you examine, there will be marked tenderness here in the AC joint. So that is clear cut. Bicipital is very easy. This is the area, bicipital tendon. You can palpate for this groove between the lesser tubercle and the greater tubercle. So bicipital tendinitis also, the patient will have exquisite tenderness here. That is also more clear cut. The problem will be to differentiate between frozen shoulder and the subacromial impingement or rotator cuff disease. So in that case, there will be painful arc. Here there is universal restriction of movements, but whereas for rotator cuff, the 60 to 120 degree will be very painful. When you ask the patient to abduct the arm, lift the arm, 60 to 120 degree will be painful. And after 120 degree, the patient will say, I feel more relaxed now. So that is how you diagnose a rotator cuff disease, especially subacromial impingement and supraspinatus tendinitis, rotator cuff tendinitis, they will have this painful arc. So just remember these two pathologies, rotator cuff and frozen shoulder. And this is what I told you, AC joint, they will say the pain here, tenderness here, and cross-body adduction. When you keep the arm like this, that will be very painful. And bicipital, I already told. So you don't have to remember all these things. Just for completion sake, I'm telling this because if somebody comes to you, you should not be completely clueless. You should have try to make out what is the possible cause of pain. Okay. Then investigations are same: blood, X-ray, ultrasound, and if there are any red flags, then you can go for CT or MRI. So this is which condition? So much of degenerative changes. This is osteoarthritis. This is osteoarthritis. The joint space is narrowed. Subchondral sclerosis is there. So this is osteoarthritis. Then this, I already told you, the space between the acromion. This is clavicle. This is acromion. This is AC joint. This is a humerus. The space between that is reduced. So what happens? There is one muscle which is coming from here, that is supraspinatus, that will be constantly in friction with the acromion. So what does that cause?
Bursitis.
Yes, subacromial bursitis or subacromial impingement. Okay. So this is what happening in normally you see this much of space is there. Okay. But all the subacromial impingement you will not be able to diagnose with X-ray. I just put a good X-ray. That's it. But this is easily diagnosed in ultrasound. You can see that when the patient is updating, the entire muscle is not going beneath the acromion. Better diagnosed in ultrasound. Then this is a supraspinatus muscle, the normal appearance in ultrasound. This is just to understand how useful is ultrasound. We just look how this muscle is looking like. The supraspinatus tendon getting attached to the greater tubercle. This is a normal muscle, but this muscle is thickened. It is thickened and hypoechoic. The normal architecture is not there. Somebody is unmuted. Please mute. Others, please mute. Okay, so you can see that how it is different. So just to show you how important is ultrasound. So that is how the investigations are. Now coming to management, the general principles are same as for knee pain, that is physiotherapy, lifestyle modifications, psychotherapy, the analgesics. Only thing is that duloxetine, I don't find that evidence in shoulder osteoarthritis or shoulder pain, just like in osteoarthritis. But you can give, because in any chronic pain, there will be a lot of sensitization. So for desensitization purpose, you can start, and the patients will be having difficulty in sleep. There will be some associated anxiety, depression. So you can give duloxetine, gabapentinoids, or amitriptyline if these comorbid conditions are there. And interventions are very useful because in knee, usually the diagnosis is very clear cut, but in shoulder, it's usually very difficult, which is which. So these interventions will help to find the pain generator also, okay, as a diagnosis also. And we have for frozen shoulder intra-articular hydrodilatation, because in frozen shoulder, what happens is the capsule is very tight. It is contracted and thickened. So what we do is we inject around 30 to 50 ml. Steroids are not necessary. 30 to 50 ml saline or 5% dextrose within the joint. That will dilate the joint, dilate the capsule, and the patient will cooperate with the physiotherapy better. Then you can, if there is bursitis or for joint inflammation or bicipital groove inflammation, bicipital tendinitis, we can give steroid injections. And I already told PRP has got a very good role in tendon, ligament diseases. Okay, so a tendon like this, the previous one, what is the treatment of choice at present is to inject PRP into the tendon and then do the physiotherapy. Then suprascapular nerve block. Your patient is having chronic shoulder pain. There is nothing we can help. We are not able to find a diagnosis, or we are not able to help with any of this. Then you can go for, just like in knee, there is genicular nerve block. Suprascapular nerve supplies the 70% of the knee shoulder joint is supplied by the suprascapular nerve. So you can go for a suprascapular nerve block and RFA. There will not be 100% relief because it provides only 70% of the innervation, but there will be some 50 to 70% pain relief. And so that's about a joint. So I think we'll keep the discussion towards the last, because I have only 2-3 slides for chronic calcific pancreatitis. This is very commonly seen in our pain and palliative OPDs, because these patients, initially the gastro people will be very enthusiastic in treating these patients. They do all the ERCP, stenting, duct dilatation, everything. But this keeps coming. This keeps coming, and finally they will, Sunil sir, Amrita already knows, I think still have a patient in our IP in Pallium, India, and we keep having such patients. No, I don't know how many of you see in your practice. These patients keep coming to us. And the last class I told about opioids. This is a big problem. Opioid dependence, addiction is a big problem in these patients. Their pain is unbearable. We have to start them on opioids very often, but at the same time, one pathology will come down and they will go into another pathology, which is opioid dependence, hyperalgesia, addiction, all those opioid tolerance, all those issues. So basically, calcific pancreatitis is an inflammatory condition, at least in the initial stages, that leads to progressive and irreversible destruction of the pancreatic parenchyma. What happens with the recurrent episodes is tissue fibrosis, loss of exocrine endocrine function, then the patient will develop steatorrhea, malabsorption, diabetes, and unbearable pain. Okay. And what are the predisposing factors? Most important is alcohol intake, then genetic predisposition, ductal obstruction, and many other autoimmune causes and many other factors are there. And clinically, these patients will have constant or recurrent severe abdominal pain, a deep, dull, aching kind of pain that often radiates to the back, similar to the pancreatic malignancy that often radiates to the back and is worsened by food intake. There will be nausea, vomiting, and often psychological disturbances also, anxiety, depression, and all those things. And for examination, you have to examine the abdomen for any area of tenderness, any mass palpable, and Carnot sign. So do you know what is Carnot sign? Anybody here knows what is Carnot sign? Why we are looking for Carnot sign in a patient with abdominal pain? Not necessarily chronic calcific pancreatitis. Any patient coming to you in your pain and palliative OPD, I'm having chronic abdominal pain. Nobody is able to find a cause. You should look for this Carnot sign. So what is Carnot sign is? To identify whether the pain is coming from the abdominal wall or from the viscera. Okay, so you have to ask the patient to lie down and then ask the patient either to raise the head and the upper back or the opposite. Lie down and then ask the patient to raise the lower limb from the hip, not just the legs, from the hip. So if that causes worsening of pain, then most likely the pain is coming from the abdominal wall. Okay, if it is not causing any increased pain, if no increased pain, the pain is most likely from the viscera. So why it is important in chronic pancreatitis is, I have seen at least 2 cases during my training period whom Carnot sign was positive. So instead of going for all the invasive procedures like ERCP, stenting, or a celiac plexus block, we just go for a subcostal tap block. I don't know how many of you know about this transverse abdominis plane block. The anesthetists here will know. The tap block they commonly use for perioperative pain management. So we went for a subcostal tap block, 2 or 3 sittings. The patient got some relief. Whereas unnecessarily, we should not send the patient for invasive procedures or investigations, because what happens is in chronic calcific pancreatitis for any other chronic abdominal pain, over the time, the pain generator can move from the viscera to the abdominal wall. Okay, earlier the pain might have been originating from the viscera, but now it is from the abdominal wall. You can go back and read. There are so many articles on this particular point. So that is why we have to check for a Carnot sign in any patient with a chronic abdominal pain. You can very simply differentiate. I don't say that it is very sensitive and specific, but as a screening tool you can use to differentiate whether it is visceral or coming from the abdominal wall. Okay. Now, the diagnosis, because imaging studies, you have to look for anything that might have caused this particular period of worsening. Okay, strictures, stones, and pseudocyst. So recently we had a patient in the current hospital where I am working. So when the patient came with severe pain, he was actually referred to me for morphine or intervention. But when I checked, there was no investigation imaging study in the last 4 or 5 years. And this particular worsening of pain, even though he was having on and off pain, this particular worsening is comparatively a recent onset. So I asked him, can you afford a ERCP? Can you afford another imaging study? He said, okay, we'll do that. So I sent him to the gastroenterologist. So he did an ERCP and there was a stricture and he dilated and the patient went back home and there was no need to start morphine or, intervention. So, I mean, pain intervention. So palliative care or pain and palliative care, this need not be always lo-fi, because I know that we don't want to always, we are very concerned about the cost. We are concerned about doing another invasive procedure, but still at times you may have to go ahead with that, because that will relieve the patient for the unnecessary suffering. And if you start the opioids, that also have complications. So why don't you check, is there any reversible causes before that? So you can actually convince a patient for an ERCP, because the patient was not convinced before coming to me. He told he wants something for pain relief. Then now earlier it was CT MRI, but now the choice is endoscopic ultrasound, for finding out this diagnosis of chronic calcific pancreatitis, and they do this endoscopically only, ERCP and all those things. And the management, non-pharmacological measures, the lifestyle modifications, abstinence from alcohol, tobacco, low-fat diet, then behavioral interventions, psychotherapy, because there will be some amount of anxiety, depression, and also possible opioid dependence or alcohol dependence. So you have to address that. Then pharmacological measures, you have to go up the WHO analgesic ladder, but again and again, you have to be cautious about opioids. So one study says that only 25% of patients benefit from the opioid treatment. So there should not be a rush to start on the opioids as if this is going to cure all the problems. Okay, so only 25% of pancreatitis patients, they benefit from opioid treatment. If at all you start the treatment, opioid treatment, be careful, and whatever I have told in my previous class on starting opioids for non-cancer chronic pain, you have to remember, you have to practice that. Okay. And then anti-neuropathic agents, do they have a role like gabapentinoids? Because studies say that neuritis and neuropathic pain is a predominant pathological feature in this chronic pancreatitis. So you can definitely try this anti-neuropathic agents. Then pancreatic enzyme supplementation, you can give a trial. Usually the gastroenterologist gives that a trial for 6 to 8 weeks. They may have a positive effect on the diarrhea, fat malabsorption, weight loss, etc. So these are the pharmacological measures. And then interventional pain management. So if nothing else works, even strictures, nothing, no reversible factors, then you can go for a splanchnic or celiac plexus neurolysis, either alcohol neurolysis or radiofrequency ablation of the splanchnic nerves. But when you go for celiac plexus neurolysis, the evidence says that when you compare the efficacy between malignancy and pancreatitis, the efficacy is less for. I'm not telling it is not efficient, but relatively the efficacy is less for pancreatitis. For pancreatic malignancy, there is 70 to 90% cure rate with celiac plexus block. With pancreatitis, it is 50 to 60%. So that difference is there, but you can send the patient for an intervention even before starting the opioids. You can try this if the patient is willing. Okay. So I think that's it. I have covered both joint pain and chronic calcific pancreatitis, and now the floor is open for discussion. And I should tell that before we open up for discussion, I had a very nice time with you all, and you all have been very, very interactive. I usually don't like online classes because I always feel it's like a one direction, unidirectional. But this 3-4 sessions I enjoyed a lot. So thank you all for the patient listening, and thank you all for interacting so much. Now you can ask me the doubts from this session or previous doubts and previous sessions. And if I don't know, I will, just like in the quiz competition, I will pass the mic to Sunil sir.
Madam, how do we deal with this intractable pancreatic pain without morphine? I mean, okay, I have had a patient who had been on morphine and had morphine dependency. But then again, what is the other alternative? Because without that, he is not able to tolerate.
Yes, that is what one thing is. We should see for any reversible thing like strictures, pseudocysts, or stones. Second thing is we can start on and tramadol, and we should start on a weak opioid, tramadol and pregabalin, because as the studies say, there is some role for there is some neuropathic component in pancreatitis. It is not, and then interventions also. If nothing else works, we have to start morphines. We have Pallium India. We have in Pallium India many patients on morphine for CCP, but then we have to be careful how we titrate it upwards. Just because we are, it's not that I'm not saying you should not start morphine. I have seen some, what I can say, injudicious use also. Because just because we are very confident about going up the ladder and using morphine, if you are not getting ready for 10, then go to 15, then go to 20. But we can titrate and optimize other medications, and these patients will have definitely some psychological disturbances also, because it's a chronic pain. So if we address all these things, we may be successful. Again, I'm not sure we may be successful in 100% cases. We may have to start morphine. I have also started. I think everybody here, Sunil sir, Amrita, Biju sir, everyone might have started, but just a word of caution, that's it.
Yeah, I had a tough time dealing with a young person because he was having a familial type of chronic pancreatitis, calcified pancreatitis. He was a young guy. He was diabetic. He had no other strictures or anything like that. He had been investigated multiple times. And the only thing which he used to get relief was morphine. But he was not on very high morphine, like 20, 25, he used to get relief. But unfortunately, the gastroenterologist who was treating him prohibited. He said, no, I'm not going to give morphine anymore. Yeah, because the dependency. He thought that he was dependent. Of course, he was a little dependent, but he had a lot of psychological problems because he was a young guy. He married just a year ago. His wife was pregnant, and he didn't know whether he was going to live or die. You know, all sort of lot of complications were there. But then again, when the morphine was stopped, he was, he was very, very bad. So I didn't know what to do at that time. So when the gastroenterologist was point blank, he said, no, he will not give it. So we had a tough time dealing with the patient.
Yes, and in CCP, as you told about morphine, many gastroenterologists, they say that you should not start morphine, and we feel a little sad about that. But I have seen two patients during my training period, that we have given two, like 16-year-old boys. That is, the CCP is common in the adolescent age. So 16-17-year-old, that age boys, and they both are from, this army, from the military hospital, that area. They go to the military hospital every day in the evening, and they take tramadol, IV tramadol. So this was going on like this. And finally, one day we decided to do this splanchnic RF or celiac, something. We did the intervention. The patient was completely pain-free for one day. But after 2 days, the patient again started having pain. So we then optimized other drugs and everything, and the patient was closed for follow-up. After 2-3, I think 6 months or something, I saw the patient's father. So he was telling me, ma'am, now my son is okay. I said, how? Said, he told me we took him for a de-addiction. So yeah, so they took him for a de-addiction, and he was admitted there, and the problem was tramadol dependence. So this has happened. These two boys who were neighbors, both were having chronic calcific pancreatitis. Both used to go together to the military hospital every day in the evening to take tramadol. Both we did celiac versus splanchnic RF on the same day. This is an interesting case scenario, and both got pain relief for 2 days or something. After that, the same scenario. We also had doubt, because when we used to tell them that we are giving tramadol and we'll just push IV saline, and the patient will have relief for at least for some 30 minutes. I am relieved, my pain is relieved. So that we also had this doubt, this is dependence. But then we lost the patient to follow up, and then after 6 months only I came to know the story. So we should know that there is unbearable pain on one side, potential problem of dependence, addiction on one side, and nobody else to manage. We are there. Everybody else will shuttle the patient to you. It's a very, very tricky situation. I think if Sunil sir has anything to add, you can tell sir how to deal with such a situation.
So today also we had a discussion on this because right now we have a patient,
yeah, I know
young
the patient.
Yeah. So he actually has some red flags. So we were really concerned how to go about this patient. So at last, this patient has continuous pain. It's not like once in a while. Whenever he takes food, he has very severe pain. Otherwise, also he has continuous pain. So we were thinking of some interventional pain management also, but luckily I don't know. When he came this time, he said he has good pain relief the for the last 1 week. So if he has no proper pain relief, and if he was taking lots of SOS doses, we were planning to admit him and see how directly observe opioid therapy, along with whether we can do any interventional pain management. But we also thought that by doing celiac plexus neurolysis, the effect may not last long, maybe up to 6 to 9 months. Then after that, again, he will have pain. Um, so that's one problem that we discussed. And if you put a patient on opioid for non-cancer chronic pain and give him a trial and see whether that responds to opioid, and if it responds, you discuss with the person the chance of psychological dependence. And with his consent only, you continue to give him opioid therapy, but also make him understand that so this is what the dose, and we have to agree that you will not take more than this. Uh, so there will not be any unsanctioned increase in the dosage because of the problem of addiction. So these are things you need to discuss with the patient himself. And if he also agrees, we can continue opioid therapy if he gets good relief with the opioid. If he is not having any relief, then we have to definitely have to stop. And according to CDC, I think the maximum recommended dose for non-chronic cancer pain is 90 milligram. That's what they suggest. And once you put the patient, you have to see whether that has any advantage and what are the risks and benefits. And if the benefit is more, you give him a control trial. Otherwise, stop it.
So is it 90 milligrams per day or per dose?
90 milligrams per day.
So for duration, is there any guideline like how long
Yeah,
can?
2 weeks, and you see whether that pain has. You take the risk and benefit, and if it is more of advantage, then you have to discuss with the person the risk of addiction. And actually, in US, they have an opioid agreement, uh, which is signed by the patient. Uh, but in our situation, we usually don't do, but you have to at least document it in the case sheet, saying that we have discussed with this patient the chance of addiction, and considering he has more advantage, we agreed that we will continue to give opioids, but there is no unsanctioned increase in the dose, etc.
So I have one question. This during ERCP procedures and all, when we use fentanyl and morphine, the proceduralist is concerned about sphincter of body contraction. So here we are using morphine for long term. Won't it negatively affect the disease process or the healing of chronic pancreatitis per se?
There is that concern is there, sphincter of body spasm. That is what Sir said. We can always assess the response. It necessarily need not cause. There was some study. They measured the pressure in the duct. Okay, after giving opioids, we can. I forgot which journal or anything, but there are studies. So it was not always associated with intraductal increase in pressure. Opioids, fentanyl or morphine, but this is a potential problem. That is why we have to give a trial. When we don't have anything else in hand, we have exhausted all the other resources, and I can say that intervention also, that Sunil told that about 6 to 9 months. But when you consider the potential problems with opioid dependence and addiction, not just with pancreatitis, many of these thing interventions I feel has to be considered earlier, because at least for after 6 months or 9 months, there is an option to repeat the intervention also. There's no problem in repeating, but on the other hand side, opioid addiction and dependence is going to be a lifelong problem. So anyways, we can always give that, we can always give a trial of opioids and see whether if the patient is having this significant sphincter of OD spasm, there will not be improvement and there will be worsening over time. That is why that study says only 25% of patients respond to opioid therapy.
And
sphincter of
regarding
OD spasm is not very common.
Yes, it
And
is not very common.
I have seen only one patient during this 20 years of my career of palliative care. But I also talked to Rajogopal sir, and he told he has only seen a couple of patients. So it is very, very rare. So we had one patient who was a retroviral positive patient with a malignancy. So when we gave morphine to this patient, within 15 to 30 minutes, he will complain of catching type of pain in the right hypochondrial area. That's how this occurs every time when we administer morphine. And that also decrease with higher symbiotic growth. So that's how we diagnose it as sphincter of OD spasm.
Sir, another thing is we give a lot of fentanyl PCA for in the hospital where I am working. This CCP will have acute flare-ups. The patient will come with severe acute episodes. So during that flare-up period, we commonly use fentanyl patient control analgesic pumps for like 3 to 5 days maximum, not more than that. And I also have not seen any sphincter of OD spasm in this patient because I very commonly every day I'll have at least one CCP patient there with acute flare-up. But another thing I have seen is with 3 to 5 days of fentanyl and other supportive treatment by the gastroenterologist, many patients are lucky that it's not that the pain will come down to zero, but it will come to a bearable range and then they get discharged. But for some patients, this will continue like anything, and that is when we have to think about interventions or opioids. Not all CCPs are very bad.
Madam, as you said, this flare-up of this particular pain, this particular patient whom I had, he used to respond better with the pentazocine than morphine.
Okay.
Pentazocine,
okay, sir. That is there. We can try opioid rotation also. If it is not, that is something sometimes I see this injudicious usage that even when the patient is not responding to 10, go to 15, then to 20. Think of opioid rotation then.
Yes.
We can try alternate opioids.
This is regarding de-escalating opioids. When we start for non-cancer pain, is there any standard way how we can start de-escalating opioids? Like once the need is met or we have done an intervention, is there a procedure to de-escalate opioids?
No, actually, it is the same for, I think, cancer also. So 1/3, right, sir? So, sir, by 1/3 we reduce. That is how we do. By 1/3 you reduce and give it for 2-3 days, and then again in that way. Not specifically for cancer, non-cancer. It is same for everyone. Whenever we are de-escalating opioids.
So we have seen that some patients tolerate this type of de-escalation, but very rarely some patients will not tolerate, and then the patient will have symptoms of withdrawal. So in such patients, you have to do it in a slower phase.
And if you have any doubts from the joint pain or the previous classes also, we can discuss here. Or from CCP also. Stop sharing. Yes.
Ma'am, yesterday there was my neighborhood, a postmenopausal female, age around 54, I think so.
Yes.
She complained of pain in the upper arm near the right below the joint, not exactly in the joint. I just palpated, but it was not found to be the joint tenderness or no such restriction, no restriction of movements and no uh, inflammatory findings were there.
Okay.
It seemed to be from the muscle kind of thing. So what could be the pain generator in this one?
Now,
And there is
which
no
part of
injury also. No?
which
Near
part
the
of the
biceps.
near the biceps? Okay, it can be because deltoid comes and covers till the the middle part of the humerus. So it can be from deltoid. Deltoid myofascial pains are very common, and it can be from the biceps muscle also. It may be a primary myofascial pain only because the female, no, they will have to do this roti making and all these activities involve a lot of abduction and all those things. So it can be a primary myofascial pain also. If there is no joint restriction of movement, no joint line tenderness away from the joint, it can be a primary myofascial pain. And only one thing is in this location that you said is this bicipital tendinitis, which comes here. It will be away from the joint line, somewhere here. You have to palpate, and if there is severe tenderness, it can be this bicipital tendinitis. And those patients will say they will have difficulty in holding things. Usually shoulder pain patients, frozen shoulder, rotator cuff, their problem is in lifting the arm or reaching back for dressing. But bicipital tendinitis patients, their pain will be in the anterior shoulder, as you said, away from the joint line, somewhere here, and then the patient will have pain while writing for some time or doing the kitchen works for some time, they will have pain. So it can be bicipital tendinitis or bicipital tendinopathy or a primary myofascial pain of the deltoid or biceps.
Okay. He also gave a history that the pain gets relieved by some activities, routine day activities. The early morning or in the morning hours, it was more, but later on when she was doing her household works, it's getting relieved during the rest of the time, rest of the day.
Like someone, if you are feeling an inflammatory component, it may be bicipital tendinitis. Anterior shoulder pain with some inflammatory, this thing can be bicipital, because whenever there is inflammatory component, there will be accumulation of this fluid whenever you are stationary. So as soon as they do some activities, there will be some circulation, the fluid will be removed, and the patient will feel better. We say that in the joints, gelling phenomenon, when the patient remains stationary for some time. So maybe there is an inflammatory bicipital tendinitis. And even though we have discussed all these things, all the points will not. I have seen an inflammatory arthritis patient. History-wise, typically everything is looks like a degenerative arthritis, but I think more joints were involved. That is the only reason I asked for an ESR CRP. And after I sent to a rheumatologist, and it came out to be some subset of inflammatory arthropathy. So all these, whatever I have taught, the inflammatory, degenerative, even low back pain, what worsens spot, all these are the general. This thing does not apply to every patient. There may be exceptions.
Thank you, ma'am.
I think, sir, there are no other questions.
Vineetha has. I myself had a severe bilateral shoulder and upper arm pain for the past 3 weeks. With extreme fatigue, I ruled out one after the other course and found that my TSH was raised to 21.9 from 1.3. After starting some generic medicine controlling thyroid diabetes.
Yes, 3 weeks means it is a acute pain. Whenever the pain is acute, we have to look for more causes like this. The blood investigations, everything becomes more important. Generic medicines, okay.
I learned not to believe generic medicine. Okay. So we would wind up the session for today, but for the past 3 sessions, I believe we were able to get some facts about non-cancer pain. At least we understood the language of pain generator It will not be always from the malignancy or something else, which we usually look, but there are many other common causes which can produce pain, and now we can use median, paramedian, all the languages, and maybe even you can talk to your colleague with this language, and they will understand that you know something about the pain diagnosis. But I am sure when you go through the presentation and module, you will understand it better. And this is going to be very would be a good tool in your armamentarium. Um, because pain is one of the most common symptom that is seen in the patient, and that is the second most common symptom in cancer patients. And in non-cancer patients also, we see pain very common. So I think there is no other person to tell us regarding the chronic non-cancer pain, because Vineetha herself has very good experience in palliative care, and then she took fellowship in um, pain management. So thank you, Vineetha,
Yes, sir.
for this long 3 sessions and taking all the trouble to teach us. Thank you, everybody, for your active participation.
Dr. Vineetha, one word of thanks to you from my side also. I mean, dealing with palliative patients, whenever somebody used to come with chronic backache or some other pain which is not related to cancer, we used to always shun them as it is not our field of interest or our area of expertise. Please go to the orthopedician or rheumatologist. But then when you started speaking about a non-cancer patient, that's when we also saw that we also can help these patients because they really suffer. And so we should try to help them rather than shun them to specialists and then say that it's not our field of expertise. Thank you so much for your insight.
Yeah, thank you so much. And actually, I don't know how many of you are practicing now. Other people might be thinking why this is so important, because once we start practicing, we get a lot of these chronic pain, non-cancer patients also. And if we are completely clueless, then we will not be able to help them, and they are already shunted from everywhere else. And we will also tell them you go to some other doctor. So it is we should have some idea about. We all should have some idea about non-cancer chronic pain also. And my virtual gift to Shravani and Kevin. Shravani for identifying my case scenario as a lumbar disc disease, and for Kevin, Dr. Kevin, for the iliotibial band syndrome, and so many other virtual gifts also, Dr. Puneetha, Dr. Parul. So many people have been very, very interactive and answering so nicely all these days. So I will someday, now virtual gifts for now. Actual gifts like we can share later on.
When you meet them at File in India.
Yes.
Sir, I found some lignocaine patches in Amazon.
Okay.
I don't know whether they are reliable or not.
Yes, yes.
What is the percentage?
They have given it as some. It's not 5%. Lidovalor is available in Apollo pharmacies.
Now, I told
deliver
that last
anywhere.
class also, there are so many duplicates or I don't know coming up. In the last conference I went, it was where? Orissa. They were showing me one patch. It was 5% patch only, but they were telling it was of longer, 48 hours or 72 hours, I don't remember. They were telling that also capsaicin, also they were showing some newer companies and new this thing. So I don't know how much to believe. Capsaicin patches are available here, but honestly, I didn't get any benefit from using them on PHN patients. The locally available capsaicin patches are there. So we are, but the ones we import directly from the companies, for especially 5% lignocaine, capsaicin, there are certain good companies that are producing, they are beneficial. But many locally available things are there, just like you said in Amazon, India Mart, and all these things. Many companies are there. I don't know how much we can trust that.
Okay. Sripriya, it's over to you.
Thank you, Dr. Vineetha. This has nothing been short of a journey, I believe. 8+ hours of discussion, and still the doubts are coming in. The discussion is going on, nothing short of a journey. And we strongly believe that the footprints made by this journey, this education of pain, is going to last a lifetime in all our fellows' career. Thank you so much for enlightening us. And just reminding that from tomorrow, we are officially entering the clinical posting phase of our global fellowship program, and are expecting fellows to come and meet us in person at Pallium India. This is Sripriya, along with Dr. Vineetha, Gopal, and Dr. Sunil Kumar, signing off from the Pallium India's presentation desk. See you in the next session, that is going to be tomorrow, with another interesting topic and 2 eminent speakers. Till then, everyone take care. Bye-bye.
Thank you.
Thank you.